So what we're going to do now is look at the causes of shock, and as we do this it'll give us a classification for describing shock that may arise in our patients. And the first one is probably the most common one we come across in clinical practice, and it's hypovolemic shock. And if we look at the word, hypo means low, vol means volume, and emia, of course, is in the blood. Hypovolemic shock. And this will happen any time the volume of the blood is too low. If the volume of the blood is low, that's going to reduce venous return, less blood going back to the heart. If there's less blood going back to the heart, less blood will be pumped out from the heart. The heart obviously cannot pump out blood it has not received back first. So the hypovolemia will cause a reduced venous return, and the reduced venous return will reduce cardiac output. But there's different causes of hypovolemia, and the first one we notice here is hemorrhage. This is sometimes called hemorrhagic shock, but actually it's a subdivision of hypovolemic shock. The patient ends up with low blood volumes. And this can occur for several reasons. The most common ways to classify hemorrhage is external or internal. So external hemorrhage would be hemorrhage that you see. The blood is going to leak out from a wound and be visible on the surface of the patient's body. And usually you can see how much blood the patient is losing. But it's always important to get a history as well, because the patient may have lost a lot of blood before they arrive in your care. So it's always worth saying to the paramedics, was it a bit of a bloodbath at the road traffic accident? And they might say, yes, there was lots of blood, or no, there was very little blood. So you can kind of start getting a picture in your head of how much blood the patient's actually lost. So external hemorrhage can be assessed visually, usually. But of course, hemorrhage can also be internal. It's possible to bleed into body cavities. Now, in various places in the body there are potential spaces, for example in the peritoneal cavity or the pleural cavity, and blood can leak into these potential spaces. And of course blood can also be lost through long bone fractures. There's a saying, on the floor and 4 more. That's where blood can go, onto the floor or 4 more places. That is into the thoracic cavity, into the abdominal cavity, into the pelvic cavity, especially if the patient's got a fractured pelvis. You can bleed torrentially from a fractured pelvis. And the 4th is in the limbs, often due to fractures of the long bones. Remember, huge amounts of blood, 1 litre or more of blood, maybe up to 1.5 litres of blood, can be lost through a fractured femur. 750 mils of blood can be lost through a fractured tibia. So think about where this blood might be going. It could be on the floor or 4 more places, on the floor or 4 more. Sometimes, not common, but you can also become hypovolemic as a result of blood loss from viral hemorrhagic fevers. Dengue is a possibility, or even something like Ebola. Viral hemorrhagic fevers, also worth bearing in mind if you live in that part of the world. Next cause of hypovolemia we're going to look at are burns. Now, burns can be caused by anything hot, obviously, steam, water, hot objects. But in this classification, we could also include things that are very cold, because we do talk about cold burns. And this damages the surface of the skin. And if the surface of the skin is damaged, it's no longer waterproof. And a lot of water can evaporate from the tissue fluids in the body out to the external environment, just because of the loss of the waterproof integument. And as well as that, burn injuries cause huge amounts of inflammation. So when someone gets a burn, there is a profound inflammatory response in that area. And of course, when there's inflammation, the small blood vessels, especially the capillaries, are going to dilate as part of that inflammatory response. Because the capillaries are dilated, they are more permeable to water and plasma, and fluids will be lost, will be exuded from. There will be exudates of plasma from the capillaries, that is from the intravascular compartment, into the tissue spaces. There'll be a lot of inflammatory exudate, And of course, this is all fluid that is lost from the blood. And it's useful when someone comes in to be able to quickly assess how much of the body surface area has been lost in a burn. And you can do this quickly with what's called the rule of 9. And we say that an arm is 9% of the body surface area, that the head is 9% of the body surface area, that the front of the torso is 18%, that is 9% and 9%. Again, the back and the buttocks we say is 18%, so again, half of that area would be 9%. And we also say that a leg is 18%. So if the front of it, or the front of one leg is burnt, that would be 9%, or if all the back of a leg is burnt, that would also be 9%. And we also normally say that the groin is responsible for 1% of body surface area. So a lot of fluid can be lost from burns. Next, dehydration. Now, dehydration just means there's an excessive loss of water from the body, and it's got many possible causes. The most obvious one is that someone just doesn't drink for a period of time. They might have been walking through a desert and not been able to gain access to water. That can cause dehydration. But more commonly in the clinical environment, we see it as a result of diarrhea and vomiting. So diarrhea, there's an inflammation in the colon, large amounts of fluid can be lost. Again, vomiting, especially repeated vomiting, large amounts of fluid can be lost. And of course, whenever we're talking about losing fluids in this way, as well as talking about fluids, we also need to think about electrolytes. So typically with diarrhea and vomiting, large amounts of potassium can also be lost, making the patient hypokalemic. Diarrhea and vomiting, particularly a problem in children. Diarrhea and vomiting, tragically, is still one of the leading causes of death, and perhaps the leading cause of death in the world in children under the age of 5, because they have a relatively small blood volume, and if they have gastroenteritis causing diarrhea and vomiting, they can become dehydrated relatively quickly and they can develop hypovolemia, which of course is a life-threatening condition. But there's also medical causes of dehydration. For example, in badly managed diabetes, the blood sugar levels will rise. And if the blood sugar level rises above about 11 millimoles, that exceeds what is called the renal threshold. And that means that glucose is going to be left within the nephrons. And if glucose is left within the nephrons, that glucose is going to attract a lot of water, because glucose is an osmotic molecule. And if the water is attracted and retained within the nephrons, that will pass out and form the urine. And in fact, we call this anosmotic diuresis. So that's quite a common finding in diabetes, that there is glucoseuria and a diuresis, large amounts of sugary urine as a result of the osmotic diuresis, leading again to potential life-threatening hypovolemia as a result of the dehydration. Now, edema is the collecting of fluids in the tissue spaces, and this can cause hypovolemia as well, and it's common after trauma, especially if there's multiple injuries. So again, if there's injuries to a large area of the body, that's going to cause an inflammatory response, that's going to dilate the capillaries, that's going to increase the amount of inflammatory exudate, and again, quite large amounts of fluid can be lost from the blood as a result of this. Now, the last classification I've got here is third spacing. What do we mean by third spacing? Well, in this context, the first space is where water is retained inside the cells of the body. That would be the intracellular fluid. But there's also fluid outside the cells, that is the extracellular fluid. And the extracellular fluid can be divided into the blood and the tissue fluid. Blood is the intravascular fluid, and the interstitial fluid is the fluid in between the tissue cells and the capillaries. So intracellular fluid and extracellular fluid are the first two classifications. And in this context, fluid can also collect in third spaces, a third tissue compartment. And these are normally potential spaces within the body. So fluid could collect in the pleural membranes, between the pleural membranes, causing a hydrothorax. That can occur in some malignant conditions, for example. Or fluid could collect in the peritoneal cavity. For example, if someone has peritonitis and there is gross inflammation of the peritoneal membranes, that can lead to a lot of fluid collecting within the peritoneal sac. Or if someone has a gastrointestinal obstruction, the fluids can't get through the gastrointestinal tract, and there's going to be a lot of fluids collecting above the obstruction within the lumen of the gut, within the lumen of the GI tract. And again, if several litres of fluid are inside the GI tract, that is fluid that is not available for circulation in the intravascular compartment. Therefore, the volume of the blood will drop. The patient will be hypovolemic as a complication. Now, the next classification of shock or cause of shock is cardiogenic. Cardio, heart, genic, beginning. So cardiogenic shock is a shock which begins with the heart. There is some problem with the heart. You could call this pump failure shock. The heart's supposed to be contracting, pumping out the blood, generating the blood pressure, but this is done inadequately. Pump failure. And one reason this can occur is myocardial infarction. So if there is a coronary arterial thrombosis blocking off the blood supply to an area of myocardium, an area of myocardium will die. That will cause a myocardial infarction. And if sufficient of the heart muscle dies, there's going to be a reduced amount of contractile muscle left, and the blood pressure will not be generated as a result of left ventricular contraction, because of course the dead muscle will not contract. So myocardial infarction, one possible cause of cardiogenic shock. And normally, of course, as blood goes through the heart, the valves prevent reflux of blood. So we have the atrioventricular valves between the atria and the ventricles, and we have the aortic and the pulmonary valve between the ventricles and the large arteries. So the valve between the left atrium and the left ventricle is the mitral valve. The valve between the right atrium and the right ventricle is the tricuspid valve. The valve between the left ventricle and the aorta is the aortic valve. And the valve between the right ventricle and the pulmonary artery is the pulmonary valve. And if any of these valves cease to function, the blood will no longer be channeled through the heart unidirectionally. There will be reflux or regurgitation of blood. And if there's a massive valvular failure, that can cause a very acute cardiogenic shock. So valve function, absolutely essential. Something goes wrong with the valves as a complication of valvular disease, cardiogenic shock can ensue. Now, dysrhythmia means any abnormal rhythm of the cardiac contraction. So normally, of course, there should be a sinus rhythm with a P, Q, R, S, T in the right order, and that should be fairly regular. If the rate is between 60 and 100, we describe that as a sinus rhythm. So normally there should be a P, Q, R, S, T in the right order, and it's regular. But if there's a disturbance in the rhythm of the heart, then the heart may not pump as efficiently as it should do. In atrial fibrillation, for example, the atria can just flutter and fibrillate and not contract effectively as they should do. They just flutter. Atrial fibrillation, atrial flutter actually is something slightly different. But in atrial fibrillation, the atrial muscle just fibrillates. You don't get the normal atrial contraction. And this reduces the pumping efficiency of the heart to some extent. But if there's disruption in the ventricular myocardium, for example, if there's a ventricular tachycardia, where the ventricles are contracting very quickly, or there's a